Well, hi everyone. Welcome to our workshop presentation, Don't Ignore Your Pelvic Floor. For anyone who doesn't know me, I'm Elizabeth Hills. I have been working as a certified personal trainer since 2016, serving clients both online and in person here in Lake Oswego, where I live. And I work with all types of people, but my main clients are folks in midlife, 30s to 60s, but really like 40s and 50s are kind of my primary clients. And I'm always looking for ways to support my clients on their journey of just physical health. And I actually have a mission statement for my work. And that mission statement is to help individuals improve their quality of life with sustainable fitness strategies to stay active, injury-free, feel their best, and have more fun. So with that frame of mind, there's nothing less fun than having things like low back pain, urinary incontinence, painful sex, all kinds of things that come with pelvic floor challenges. And yet, as a certified personal trainer, I don't have a real wealth of knowledge about pelvic floor health. It's an area of the body that a lot of people are shy about, doesn't get a ton of attention in a lot of places, even in my training as a personal trainer. So that's why I'm so happy to meet Eryn, who is an extremely knowledgeable pelvic floor physical therapist. I'll let her introduce herself in just a moment. But just we wanted to open up a dialogue and just let this be a safe space to bring questions and gain a little bit more understanding about all the areas of our physical health that are really impacted by the condition of our pelvic floor and what can be done about some of the things that are going on that cause a lot of frustration and ranging from inconvenience to downright like debilitating, right, in your life if your pelvic floor is not healthy. So Eryn, I'm going to turn it over to you. Take it away.
Awesome. Thank you.
Yeah, I'd love for you to
I'm
introduce yourself.
Eryn. I have been a pelvic floor physical therapist for about 9 years now, and it's always been my bread and butter. It's always been my interest and my passion. So been at different clinics throughout the Portland metro area for a while. And a few colleagues and I decided to open up a clinic about a year and a half ago that is a clinic that specializes solely in the treatment of pelvic floor dysfunction and pelvic health. So that is what we do. And I'm board certified in it. I think there's different routes you can go to become board certified. I knew it's what I wanted to do. So in the beginning of my career, I did that. So with the years that have gone by, of course, as you get more experience and you see so many different patients, you start to understand the breadth and the complexities of pelvic floor dysfunction. So we really wanted to make a workshop that just explained what pelvic PT is, how it can help, and then also what we see throughout the for the most part, we're going to talk about the female pelvis here, but I'll briefly mention in my presentation about the pelvic floor and male pelvic health and all that. But really learning what pelvic floor dysfunction might look like through the time or the lifespan, but really then targeting it in, like Elizabeth said, with patients more in kind of that middle life, kind of perimenopause, menopause phase, to learn that there's so many things that you can do to help with conditions that most people just go about their life assuming is just part of getting older. So we'll talk more about that. So that's my background. So I'm going to go ahead and screen share here and get that presentation pulled up.
Yeah, that's so great. I think a lot of people suffer for a long time thinking that it's just typical. I mean, we kind of laugh off a lot of things related to pelvic floor dysfunction, which I'm sure we'll get into as we get into this. But yeah,
exactly.
So glad to be able to kind of talk about there's an alternative.
Yeah.
To the
Yeah.
suffering.
And like you said, starting that dialogue, I think there's so much like embarrassment or whatnot. And just really, I mean, it's all I treat day in, day out. There are so many people that are struggling with it. So to me, it just seems like this obvious thing of like, oh, well, you're dealing with XYZ, then you go to a pelvic floor PT. Wow, that rhymed. I literally never had to rhyme. But yeah. And so I think by having this information, knowing what to look for, and then also just sharing if someone feels comfortable, like even talking to their girlfriends about it, because then it's like they might feel more comfortable seeking that care out. So let's get started. All right. Yep, let's see. There we go. Okay. So just a little bit of background on pelvic floor physical therapy. It is a niche within traditional orthopedic PT. So, or I shouldn't even say orthopedic PT, it's a niche within PT in and of itself. So every physical therapist that provides pelvic floor physical therapy is a physical therapist first. And then after you graduate, or even during a little bit, you can start to dip your toes into the specialization. But it is a highly specialized subfield that you take. It requires extensive out of once you're done with your doctorate degree, more training. And there's different levels of training, right? There's PTs that have had a little training and there's PTs that have had a lot. And we all start somewhere, right? But making sure you find a pelvic PT that feels like a good fit for you. And maybe if it doesn't work one place, then maybe seek out again, because there's different, like any other provider, right? Like you might not have a connection or whatnot to someone. But it's been around since the 80s, but it has taken so long to become even a concept that people are talking about. It really did start traditionally more with pregnancy and working on incontinence, and those were the very basics. But since that's been multiple years now, 50 years, it truly, or not 40, there we go. It's not the 1930s yet. Has become, we've learned so much more about the complexities of the pelvic floor and how it interacts with all the different systems. So my goal in life is by the time I retire to have pelvic floor physical therapy be just such a common concept and a household concept that people know, like, just like if you hurt your foot, you go to a podiatrist, that if you have anything going on with your pelvis, you go to your pelvic floor physical therapist, because for most people, it doesn't even require insurance or a doctor's referral. For most, because pelvic floor physical therapy is considered, in terms of insurance's lens, the exact same thing as physical therapy. It's not different. So it would fall under that, under like if someone wants to use their insurance for that. And you don't need a referral to come in at all either, because most insurances don't require that at this point, especially with our clinic, who we are predominantly a self-pay. So that makes access a lot easier for people. So we treat, and we'll talk a lot more in depth about all of these that are listed here, but just so I can kind of give an overview, we help treat any sort of bladder issues. So because the bladder sits within the pelvic bowl of muscles, which I have my pelvic model here in a minute, so we're going to look at that entire system. But the bladder issues can involve any sort of incontinence, as Elizabeth was mentioning, in terms of any leakage. And I think the word incontinence gets, people get confused with that. A lot of times people will think that means just full bladder loss, but really incontinence means any accidental leakage. So even just a couple drops with a cough or a sneeze or jumping, it doesn't mean just loss of your entire bladder control, which can happen too, but there's different stages. And knowing that if you are struggling with any accidental leakage, that is a sign that something is not working how it should, and that there's something you can do about it and to address it sooner rather than later. Because as you age and as we get older, it does get harder to treat. Not to say you can't treat it, but someone in their 90s is going to be a lot harder to help with that incontinence versus in your 40s, 50s, 60s. So that's the incontinence component of bladder issues. The other is more what we call urgency and frequency. So the sensation of feeling like you have to pee way more often than your friends, that you're always the one stopping on road trips to have to find a bathroom, the triggers of urgency of you get home from running errands and you push your garage door opener and all of a sudden your bladder is screaming at you. You put your key in the door, you're washing your hands and you hear the running water. There's all these triggers that can start to create this sensation of urge, and not just a normal urge, because urge is normal, right? We should feel our bladder when it's filling. But it should never feel urgent, like oh my God, I gotta go and run. So those are the main kind of bladder issues we treat. Sexual function issues, any sort of pain or discomfort with sex. Sex should not be painful. It should be pleasurable. It shouldn't even feel like, it should feel good, right? It shouldn't even feel like, oh, I can get through this. It should feel good. So helping people with that, oftentimes that can be multiple factors involved, and we'll talk more about that. Bowel issues. Constipation is a big one that we help treat, which that obviously is a bigger picture. I want someone to be also seeing their other providers, right? Which to address all the different, gut issues, but we can definitely help with some parts of that, as well as any sort of bowel urgency. So we talked about the urinary urgency, but other people can struggle with bowel urgency or even bowel incontinence. And that gets into a whole nother realm of people being embarrassed, right? I think a lot more people struggle with that, especially patients that have had any significant perineal tearing during their deliveries. what we find is it's a lot more common to have leakage of bowels when someone's had a 3rd or 4th degree tear during their delivery, because that's impacting a lot more of that anal sphincter tissue, which is what helps to create that tight seal. So we can help with that as well. Pain in general, we already kind of talked about pain with sex, but pain in general, any pelvic pain condition. And that is a huge array of different conditions that we'll talk a little bit more later. But the component of that, that I think you mentioned, like low back pain, is there's a huge correlation. The research shows that low back pain and pelvic floor muscle dysfunction go hand in hand. And a lot of times, if you're seeing a traditional orthopedic PT, you're working on a lot of core work and all these good things, strengthening, posture. But the pelvic floor is such an integral part of that. And sometimes that's the missing piece. So if people are getting better, right, you go to PT, you go to a personal trainer, you're working on strength, everything's getting better, but it's like, it just still bothers me sometimes, especially the SI joint, which we'll talk about more later. That pelvic floor can be a really big piece. Yeah. As well as hip pain. That's the other part, because it's also interconnected. And then I just almost mentioned within that we're core specialists. So we really understand the complexities of the whole core system, which can help treat any sort of postpartum, right? Because the core really needs a lot of special attention and love in those postpartum time frame. And honestly, once postpartum, always postpartum. So it really takes specific training to get your breathing pattern down right again. And if someone has a diastasis, which is essentially a separation of those abdominal muscles postpartum, we can help with that as well. So I'm going to talk now about, I have my trusty little pelvic model. Talk about the different areas, because the pelvis is such a 3D complex area that I think sometimes when you see it in a 2D book or picture, it's really hard to understand, like, where are the muscles? Where is the bladder? Where's my rectum? Where's my uterus? Where's my back? So we're going to go over all of that so we can see. But first of all, the 5 main functions of the pelvic floor, we learn it as the 5 S's. Make it easy to remember, is support. So it's supporting the pelvic organs and support for your posture. It's helping with stability. So it's a huge part of our stabilization system for our low back, our lumbar spine, which is our low back, our pelvis, and our hips. And then we have the sphincteric control. And those are the sphincter muscles, which is just a fancy word for a circle muscle that goes around the urethra and the anus so that we can hold back when we don't want to have a bowel movement or pee, or when we do want to go, they open up nicely and relax and let us go easily. The 4th is sexual functioning, because of the different nerves we have down there and the reproductive system and all of that. And then this sump pump is a little bit of a weirder word, but that's essentially helping to get lymphatics and flow because of the movement of those areas. It's helping to kind of pump and move lymph fluids. So that's the functions, but now we're going to look at the pelvis. So I always like to start with the bones of the pelvis, because the bones are what create the infrastructure and the muscles kind of surrounding. So we're going to start with
Eryn, really sorry to interrupt, but maybe for a quick second, you can go back rather than sharing the slides so we can see your model.
Oh yeah, thank you. That's a really good idea. Yep.
I don't want to miss
Perfect.
this.
Thank you. No, that's a great idea.
Yeah.
I realized that. I was like, oh, it's a tiny one. And I realized everyone saw it tiny. Okay. So the front of the pelvis, we have on either side, these big bones here are called the ilium. And then we have the iliac crest, which if you're looking at someone from the side is what you see right up here. And that's what you would feel if you kind of take your hands and the top of your hips and you kind of move around. And then when you come to the front, most people call this their hip bone, but those are the 2 little projections that you feel in the front of your pelvis. And you're just feeling essentially this bone that's kind of jutting out here. So we have one on either side. And then if we follow those all the way down to the front, you get to your pubic symphysis or your pubic bone, which is that bony area you feel way down low in the very bottom part of your abdominal wall. Then, on the either side of the pelvis, there are these 2 big, deep sockets called the acetabulum. And that's where our femur bone or our thigh bone sits in. And that's where we would walk or run from. And then if we come to the bottom of the pelvis, and this is obviously a female model pelvis, but we would get to these bones at the bottom. So it's like someone would be laying on their back and we'd See that? These are the sits bones. So those are those little knobs you feel when you rock side to side on your glutes, and you can kind of feel those knobs underneath the, or those bones underneath the glutes. So that creates the front or the anterior part of the pelvic bowl. Then if we come around to the back, the ilium come together on either side and connect to the sacrum. And the sacrum is just a bunch of vertebrae kind of fused together into this triangular shape. And then on either side, where the ilium and the sacrum come together, creates the sacroiliac joint, also known as the SI joint. And a lot of times people struggle with SI joint issues, or they'll say something to the effect of my SI went out. And that's a terminology we're really trying to get away from, unless someone's been in a really traumatic car accident or is pregnant, because sometimes with pregnancy, there's a lot more looseness in the system. But in general, this is an incredibly strong joint. There are ligaments in between, and it's hard to see here, but see the amount of surface area all the way here and all the way back here. It's thick. And there are ligaments in between those bones called interosseous ligaments that literally create like a glue. And then we have all these really huge ligaments on the front and back that aren't shown on this model. So my point is, it's very strong. So it's not necessarily going to be like slipping out of place. It's usually muscle imbalances and weakness patterns and things like that, and irritation, inflammation that's creating it feeling like, I mean, it can be very painful. But anyway, that's just an area that can be very impactful in someone's life and can struggle with, and the pelvic floor can be a component. So that's the SI joint. Then we have the sacrum. Then we have the lumbar spine. The lumbar spine, I'm going to flip this around just so you can see the front, is where we start to have the discs in between the vertebrae. So we have the disc vertebrae. We have 5 of the lumbar vertebrae, and then we would have our thoracic spine, which is our mid back, and then our cervical spine up to the neck. And then at the very base of the spine, we have the coccyx, which is this, or the tailbone is what it's also called. And that's the teeny tiny bone that you feel at the very base, that if some people have had a fall on it, and it can be really painful and take a long time to heal. And that's definitely something that pelvic PT can help with. A lot of people just struggle. And they, will go, and chiropractors can help with it too, for sure. But sometimes chiropractic, it doesn't help it because we can do internal work to actually help the muscles relax. So that's a component we can help with. So that creates the back portion of the pelvis. So all together, that creates a big shape, like a big bowl. But the bottom of the bowl is not bone at all. The bottom of the bowl is muscle. So let me see if I can see here. Oh, that's hard to see. And in person, I usually lift, well, that might work. So if someone was tall and we were looking from below, there's this layer here that you can see is a little bit more external or superficial. It's more on the outside, versus this here is a deeper layer. So we have different layers of the pelvic floor for different purposes. So we're going to go over the different layers. So this would now be more like someone laying on their back, so that we can actually appreciate the different layers of the pelvic floor. This layer right here, which kind of goes around the anus, you can kind of see the difference. This is the other layer. This is this layer, and it comes up and across and here. This layer has 3 different main functions. The first is helping with stabilization, because the muscles go from your sits bone to your sits bone, and they go from your pubic bone all the way back to your tailbone. So every time you move or do anything, even just lift an arm quickly or shift to the side, you don't feel your pelvic floor doing anything, but it is constantly working for you. It's tightening when it needs to, it's relaxing when it needs to. So stabilization is key, or part of this system. The second is continence. So like we talked about, there's that sphincter around the anus that should be able to close really tightly when we don't want to have a bowel movement, but should open and let us go when we do. So that's a component of constipation. If someone has a really tight pelvic floor and they can't open that, they're going to be straining a lot more. And then we have the urethra, and the urethra, so that would be the vaginal opening. And then the urethra sits right at the top. So that little hole at the top. So we have the circle muscles around the urethra that also should be able to close off when we don't want to go. Third function is sexual. So we have nerves that bring sensation to this whole region, including the nerve that travels right up here to the clitoris, which lives just kind of right over the top of that pubic bone there. So those are the 3 functions of more of the outer layer. And the inner layer, before we look, and we're going to look inside. Remember how that outer or that deeper layer was here, but now we're going to flip the pelvis over and look in. But before we look at that muscle layer, we have to look at where the organs live, because that's why the pelvic floor physical therapy helps with all these other issues. So the bladder sits right behind your pubic bone. So boop. That's why if it's really full and someone pokes you in your lap or sits on you can feel it because your bladder is like right there. And then right behind that, we have, this would be kind of the vaginal canal, where I'm holding is the uterus, and then the ovaries on either side. Let's see if I can do this. That sits in like that. So it sits right behind the bladder. So the uterus almost does this little bit of hugging over, kind of tilting over the top of the bladder, right behind it. And then the rectum comes down behind everything. So all of those organs are situated in really specific places within the pelvic bowl. And we have different structures that help to keep those organs where they need to be. We have ligaments from above. I always think about it or teach my patients that they're like puppet strings that are helping to kind of lift from the top and lift from the side to help keep everything lifted. Second thing we have in there to help lift is fascia. And fascia we have all over our body, right? We're always on our foam roller, we're rolling out our fascia, and fascia is really important in our body. And there's fascia in our pelvic floor that's creating these like layers of lift to help lift everything. But lastly, if we remove all these from where they were, we see that they're sitting right on top, whoops, muscles down, of this layer. And this layer is called the levator ani. So hence the term levator. Its main function is to elevate and lift all of those organs that were sitting on top of it. The other function it has is stabilization, because the muscles start on the backside of your pubic bone and sling all the way back to the base of your spine. And they do that on either side. So that's why they're such an important part of that core stabilization system. So that's an overview of all of the muscles, and we'll talk more about kind of how they work in a little bit. So let me go back to presentation here. So now I'm going to go through more of the kind of time frame or lifespan of things to look out for that might indicate that there's some sort of pelvic floor dysfunction. And I've kind of done it by decade-ish. So teen years, I don't see a lot of teens, but I do see some. Some of the things that we can help with is dysmenorrhea, which is painful periods. And that can be caused by different things. One thing that we are finding is that endometriosis is impacting a lot more women than we ever thought, which is a really painful condition, and it can start to show kind of symptoms earlier on in the lifespan, where people just, for a long time, if you had really painful periods, it was like, suck it up, just get a heat pack, take tons of ibuprofen. But if a girl is missing school for days on end because of pain with her menstruation, there's something else going on there. And so spreading that word of knowing that that is not normal. If you are just having severe pain that's limiting you being able to do anything, like cramps are normal, but severe pain is not. So we cannot actually treat endometriosis personally as a pelvic PT, but we can at least, if the pelvic floor muscles are getting in on the action, which a lot of times they are because they're guarding, they're in so much pain, then that's going to add a whole layer on top of it. So we can at least help with that, and we can help be their guide, because I think a lot of times female or women in general need advocacy in our system, let alone younger girls who are just kind of like, I don't know what to do. So that's one thing we can help with. The other is called vaginismus. And vaginismus is an actual narrowing of the vaginal canal. So when we looked at these muscles, I know this is small now, but the muscles that kind of go around the opening of the vagina, as well as these muscles deeper, if those are all holding on to a lot of tension, that can actually create a really narrowed canal. And it might not even be an issue for someone if they're not even sexually active at that point. But I had one patient years ago, for example, of why this would matter, is she was a swimmer and she had a swim meet coming up, but she had her period during it, but she couldn't tolerate using a tampon. So she wasn't able to do her swim meet because you're not going to wear a pad with a swimsuit. So it impacted her ability to do her activities. So it had nothing to do with her ability to have sex or to have someone be able to tolerate a speculum insertion for health reasons. And that can be caused, some people truly, it seems like I've just had that their whole life. Other times there can be a trauma component of that because our pelvis does hold on to a lot of that trauma. And then the other thing that can start to show up is stress incontinence with sports. So if girls are starting to do heavier weightlifting or they've changed the routine a lot, I've, treat different athletes that started experiencing leakage. And again, just noticing that and saying, wow, this is going on early in my life. I'm going to go to a specialist to help it, and not just saying like, being embarrassed about it and just dealing with it. So that's kind of the teen years. In the 20s, more often than not, more people are starting to be sexually active. And so then there can be the painful intercourse. The fancy word for it is called dyspareunia. There's different types of dyspareunia. There's what's called superficial or introital dyspareunia, which just means more of pain with that initial insertion, versus deep dyspareunia is more pain with deeper kind of feeling like something's getting hit up and in there. And that's something that we can help with. Pelvic pain in general, and that usually correlates with endometriosis, but not always. Stress incontinence, like I mentioned with sport and exercise, that just continues throughout the lifespan. And then something called painful bladder syndrome or interstitial cystitis. And not to say that this only happens in the 20s, but I just put it in here because I feel like this is when I start to see more patients that start experiencing it, but it can come on at any point. It's a relatively unknown condition that's very poorly managed in the healthcare system. A lot of patients don't get a diagnosis of it for a long time. It essentially feels like you have the worst UTI of your life and nothing helps it. You can only imagine how much that would impact your daily life. So we're still learning a lot about it. What we're finding is there is a massive component of the pelvic floor and a massive component of the nervous system. Oftentimes everything is in a tightened state, that very, high anxiety, oftentimes high anxiety, and really kind of stressed, sympathetic nervous system in that fight or flight state. So that's something that we can help with. And a lot of people don't realize. They'll go to urologist after urologist, and urologists will keep putting them on different antibiotics, even though they say, we're not finding any bacteria, but here, try this antibiotic. And we can only imagine what that's going to do to the gut health, and that's going to impact other structures. So it's just kind of this feedback loop. So 30s, and again, these are general. There can always be switching between, because it's not always postpartum in your 30s. It could be 20s, it can be teens, it can be 40s, it can even be 50s maybe these days. But oftentimes see these issues start to arise in the 30s. So that usually starts to go along with more of the bladder stuff, urgency, stress incontinence. And the difference is with that urge incontinence, oftentimes, it's not always, but oftentimes urge incontinence is associated a little bit more with bad bladder habits and tightness in the pelvic floor, versus stress incontinence, more often than not, but not always, has to do more with true weakness of the pelvic floor. And that's why it's important to see a physical therapist that specializes in it to know what's going on with your pelvic floor and how to address it, because Kegels are not always the answer. And we'll talk about that. And then pelvic organ prolapse can start to develop, whether that's because of a pregnancy, a delivery, heavy weightlifting, constipation. Essentially, prolapse is just a fancy word for any of those organs that we saw sitting in this pelvic bowl. Instead of being up and lifted where they were when you were like 10, over time, they start to come down a little bit, and it can lead to symptoms of feeling of kind of a pelvic heaviness, something falling. A lot of times people will describe it as like a feeling of a tampon, but they're not wearing a tampon. Oftentimes gets worse by the end of the day just because of gravity, right? When you lay down all night, everything can kind of calm and kind of back up and in. But when you're up on your feet all day, or maybe you do a workout, things can feel really heavy and uncomfortable. At this stage of life, usually what I see is that cystocele and rectocele are most common. And cystocele is just a fancy word for the bladder. And let me actually, let me stop sharing for a minute, because I think this can be helpful to see. So this would be like taking those structures out of the pelvis. So this is your bladder, and this would be the outside over here. And this is the vagina and the uterus above it. So what happens with a cystocele is that the bladder starts to kind of fall into the top of that vaginal wall. So they'll feel like there's this bulge kind of in the front part of the vagina. And then a rectocele would be more from the back, and that this part is starting to push into the back wall of the vagina. So you'll feel more of a bulge coming from the back versus the front. So that's just a way of kind of seeing it, because I think that sometimes when people hear the term prolapse, they feel or they see something down there, but they're not really sure what is happening. And then constipation. So we start to help with constipation at this, again, any time frame of life, people can struggle with constipation. Dyspareunia, again, same thing, low back pain and hip pain. So a lot of times the low back pain and hip pain come along with that postpartum time frame because of the core shifting in terms of its ability to contract appropriately and our breathing system becoming a little dysfunctional. And not only postpartum with breathing dysfunction, I see so many patients that struggle with breathing and the impact that breathing has on our entire core. I think I get to that later. And if I don't, you can remind me. Okay, so now we're getting more into 40s to 60s and beyond. Here's when we start to get into kind of that perimenopausal or menopausal state. And that is when estrogen levels start to change and they start to decrease. And estrogen is a female body's best friend. Our body relies on it. And we'll talk more about estrogen in a moment, but it can really impact all of these systems. So we start to see a lot more urinary urgency and frequency. And that can be a component of a kind of a syndrome of menopause. And then we get the stress and urge incontinence, like I mentioned earlier. We start to see a little bit more bowel or fecal incontinence of leakage, just because of decreases in tone of the muscle, hormonal changes. If someone's dealt with constipation a long time and they've strained and they're having some sort of prolapse, different reasonings behind that. Then we start to see a little bit more what's called nocturia. And that means excessive nighttime peeing. It is normal to get up 0 to 1 time at night to pee. But if you're getting up more than that, it's not necessarily normal. There are different systems in our body and hormones that as you get a lot older, it is a little more common to get up more frequently than that. But not a lot, because you still need to get good sleep. If you're getting woken up by your bladder constantly at night, you're never getting into those good REM cycles, and sleep is the number one important thing. It's more important than exercise. It's more important than water. It's more important than anything. So that's a lot of times when people are struggling with that, they're like, everything else is off in my life because I'm not sleeping. So helping people with that. Obviously, medications can play a role too. And we always try to look at medications that are diuretics, because if someone's taking that right before bed, that's going to increase that nighttime peeing as well. We already talked about pelvic organ prolapse. The only difference with this is that I added in uterine prolapse. And again, I keep saying it, all of these things can happen at any time frame. This is just kind of generalizations. This is when we start to see more of a uterine prolapse, which is when the actual uterus, instead of being kind of up and tall up here, starts to shift kind of downward on itself. So the tip of the uterus is the cervix, and the cervix almost feels like the consistency of the tip of your nose. So sometimes that's when people will feel kind of that tampon feeling, because they'll feel the cervix just sitting lower in the vaginal canal than it used to. So that's kind of the difference there versus the cystocele and rectocele. Those are like softer, smushier organs. It's like, it's a different feeling and a different look. And so a pelvic PT or obviously a OBGYN would be able to assess for that. Then we start to see vaginal atrophy, and that is just a fancy word for lack of lubrication and lack of bulk of the vaginal tissues. And that is completely due, I won't say completely, but I think mostly due to estrogen levels, because the female body really likes estrogen. And sometimes there's a lot of fear of estrogen, and we're going to talk about that in a minute based on some old studies. But in general, we didn't used to live past 40. And so some people's idea is saying, well, if my body naturally does this, isn't how it's supposed to be? Isn't this how it's just supposed to be? Like, I naturally have less estrogen, and so all these symptoms are happening. It's like, well, yeah, but you think about our catch up in terms of evolution, we're still, I mean, it's such a small time frame of living so much longer because of medical advances and understanding of health. So we're living as women, say even at 45, 50 years old, if you live to 100, half of your life, you're in your menopausal state. And you're dealing with all of these things where that didn't used to be the issue. So I think that's the reasoning. I have patients say, well, this is just how my body's supposed to be. It's like, okay, well, if you want to feel like that, that's fine. I completely, that's your opinion, and I'm not going to force anyone, but I just want to give that information. So what that can do with that vaginal atrophy is make sex really painful, really uncomfortable, having micro tearing, just not feeling any pleasure, things like that. So super important. And then dysorgasmia. I don't treat this as often, but I have, and it just means it's harder to achieve orgasm. There's just not as much sensation, things like that, less pleasure. And then low back pain, which happens at all times of life. But as we get older, it definitely seems to get a little bit worse. So more diving specifically now into what's called the genitourinary syndrome of menopause, or GSM. This list is all the things that it consists of. And I like that picture too, because it really shows like how at that time of life, like it really dissipates. And there's ways that we can replace hormones to, decrease all these symptoms. So it involves vulvovaginal dryness and discomfort. So vulva being more of like the outer area of the pelvic region, and then the vaginal or vagina is the actual tube or the inside part. So all that area can become really dry and uncomfortable, which could of course lead to general discomfort down there, but then with intercourse, a lot of discomfort. It has been correlated to urinary urgency and frequency, increased nighttime voiding, burning with peeing because the tissue around the urethra is just really irritated because of the lack of estrogen, itching, recurrent UTIs, just because there's more ability for that bacteria to kind of get in if the tissue isn't super healthy. Same thing with recurrent vaginal infections. There's just more ability for stuff to get into our system. And then pelvic floor weakness. So again, all are influenced by decreased estrogen levels. So I read a book recently, and I've been obviously hearing about this too, but this book was highly recommended to me by a naturopath that I had chatted with, and it's called Estrogen Matters. And this is like an overview and very brief, but if you have any interest, I would highly recommend reading it. But it really dispels the myths all around estrogen and why it's actually so important for the female body in every single system of our body, not just for the pelvic floor issues I'm talking about, but for heart health, bone health, brain health, all these things. There are study after study for many decades that were showing the effectiveness and the good outcomes of hormone replacement therapy. But then in 2002, there was a study, the Women's Health Initiative, that came out that the book goes into a lot more detail. Essentially, they stopped the study early because there was all this fear of, they thought it was increasing risk of breast cancer. So of course that in the media goes nuts instantaneously. And there was just a lot of misinformation and the statistics were not correct, or things in the study weren't right. But of course, that's a huge headline. So media latches onto that instantly, and we hear it as a world, right? And then the use of estrogen just absolutely plummets because of all this fear. As the years went on, people started looking into this study and rerunning the statistics and figuring out like why, because why, after all these years of nothing coming in terms of research saying that it was dangerous, why all of a sudden is it showing that? And they were able to kind of go back and say that it was not correct, but that doesn't make headlines. That doesn't make mass media. So this has lingered for 20 years now, that there's still this fear of using estrogen. And so that we're trying to dispel that. And yes, there are certain people in certain instances, maybe that wouldn't benefit from systemic. And there's different, meaning systemic is taking it, impacting your whole body, versus using it topically or vaginally, which even if someone's taking it systemically using like a skin cream, an oral, a patch, whatever it is, that doesn't necessarily impact the vulvar vaginal tissues. So using an additive, an actual topical cream in a suppository or whatnot in the actual pelvic floor area is what's going to really help more with that specific area. So a lot of times that's unknown too. Patients will, yeah, I'm on hormones, and they'll say that, but they're not actually using something vaginally. So that is, I think all I have to say about that, but I'm sure there's a lot of questions, but I would really recommend that book because it goes into so much more detail. So now to the topic of just because it's common doesn't mean it's normal. We talked about how so many people struggle with these things, but we don't really even know what's normal because we just think we've dealt with it so long that it is what it is. So I just want to go through some kind of norms or things that aren't normal that people think are. So in terms of peeing during the day, it's normal to go every 2 to 4 hours. If you're going more often than every 2 hours, unless you just literally chugged a gallon of water and had 2 glasses of coffee. Like there's certain instances where your kidneys have to just do their job. But in general, 2 to 4 hours. The normal, which would kind of account to about 6 to 8 times a day. And then at night, because of changes in there's all these different cascades of hormones that change, called ADH or antidiuretic hormone, that influences your kidneys to decrease the rate of which they're producing urine. And that's why it's normal to not have to wake up every 2 to 4 hours at night, because our body is incredibly smart and it knows we need sleep. So 0 to 1 time at night for nighttime voiding. Urinary leakage. I think this is obviously the biggest one that people just assume because they've had a baby, because they're getting older, whatever it is, that leakage is normal, but it is not normal. It is something that can be treated. And it often can be treated with pelvic physical therapy. And if it can't be treated with that, which it usually can, but there are some instances in terms of certain types of what we call urethral instability, that it can then be helped with surgery. But even if someone goes down the route of surgery, I personally, as a pelvic PT, this is my perspective, but I think it's still helpful to have pelvic floor physical therapy either before and definitely after, to make sure that surgery is as successful as possible and that you're doing what you can to, have your body naturally, be as strong or as functional as possible. And then urinary urgency. So a normal sensation of your bladder filling is normal, but not a sudden intense urge to rush to the toilet, and especially not leaking when that happens. Low back pain is incredibly common. I mean, gosh, I think it's almost every human at some point in their life has dealt with low back pain. And I think more people know that could be helped, right? They seek out physical therapy, they seek out personal training, they seek out whatnot to help with that. And then pain with sex. I think that kind of gets normalized in a sense as well, especially postpartum or especially as you're getting older, just thinking that that's just how it has to be. So how pelvic floor physical therapy can help, there's so many things we do, but I just tried to think of a lot of the general things that we work on. So posture and body mechanics is important because that's how we really live our life every day. So looking and making sure people aren't, putting too much strain on their body, doing different movements. The second one though, is what I really want to talk about, and that's the breathing system. So with every new patient, it is very rare that I would not start with breathing. Whether they have low back pain, whether they have incontinence, whether they have pain with sex, whether they are postpartum or whether they're not postpartum. Because most people in our day and age, in our society, in our life, have excess stress, which excess stress makes us go into our sympathetic nervous system, which is our fight or flight. And instantaneously with our fight or flight, we start doing, I know I'm in this tiny little box, but we do shallow breath patterns where our shoulders and our neck tighten every single time we take a breath in. And that's doing no good for your pelvic floor or your core, because we should have, and I'm actually going to take this away so I can show my hands. There should be a really natural rhythm between the diaphragm and the pelvic floor and our core. So I like to think about the core as, I use the analogy to a pop can shape or a LaCroix can, whatever can you want to use. But the top of the can is a dome, kind of our diaphragm, which is this dome shaped muscle that lives right up underneath our rib cage. It almost looks like an umbrella shape. So that's the top of the can. And then at the bottom of the can, we have our pelvic floor way down here that we just looked at. And then around it, to make the cylinder, we have all the abdominal and back muscles that create the rest of the can. But our breathing pattern is so impactful of what's happening in our entire core system that when we breathe in, using our diaphragm should move down, which then the pelvic floor way down here should follow suit and should also move down, so that the pelvic floor is getting a nice, natural, gentle lengthening and stretch every time we breathe in. And then upon exhale, it's getting this nice, natural kind of lifting back and up and in on the way out. But most of us are not using that breath pattern. Most of us are breathing, if I even show kind of my shoulders, right? Everything getting tight here. And that happens with the nervous system regulation and postpartum. And I see a huge amount. I know you treat more of the range of like, a little bit past that stage. I treat all of it, but I treat a lot of people in their late 20s, 30s, 40s in more of that direct postpartum state. And even if it's been 5 years, 10 years, anything like that, most people's breathing system doesn't necessarily go back to normal. And that's because during pregnancy, the diaphragm gets shoved way up under here because baby's taking up all the room. So trying to get that breath to move down on inhale gets really, really hard. And that's why then you add in holding kids or breastfeeding, and everything up here is just so tight. So teaching someone to get that breath to move down into their core, working on what we call 360 breathing, meaning the belly expanding, the ribs expanding, and the back body expanding, because it's like an umbrella opening, right? So when it opens, it should open 360 degrees. Most people have heard of the term belly breathing for diaphragmatic breathing. And that's not wrong. It's just slightly incomplete because we don't want just the belly to expand. Because if my belly's the only thing expanding, as I did that, you could see how my back just got tighter, right? If I make it tight, it kind of arches more, versus if I'm thinking about getting even this expansion, I'm filling in through my back, right? So I think that's almost so hard to teach people, and this is why I always do it foundationally, because it doesn't matter what someone's struggling with. If the breathing system isn't working right, it's going to be really hard.
And can I jump in and mention one other thing that I think is really relatable? And maybe you were planning to get to this, but when it comes to this is something I see a lot in my training with my clients, and it applies to men and women, is just, regardless of whether you've ever been pregnant or whatever, but our posture that we develop from our current societal, constraints of being at a desk and sitting in more of a forward position a lot, or driving your car a lot and getting very stuck forward. So then all of this is very compressed. And that is actually like a stress response posture. Like if you needed to protect your body and your visceral organs and you go into the stress response, holding this posture where you're protecting yourself sends the brain a signal like not safe, we're not safe. And then it's this reinforcing pattern, right? Like stress relates to all of these other issues where there's just this imbalance of tightness and whatever. But like when you're up tall and your posture is good, then you can actually achieve that more balanced breathing. So
absolutely. I see that all the time. And then even with that slump position, thinking from a pelvic floor perspective, when you're in that position, that's putting so much more pressure down on your pelvic floor too, right? Like that pressure system. So absolutely. Okay, let me go back to this, see what we want to go over. We have a few more minutes. Okay, so breathing, and then pelvic floor muscle neuromuscular assessment and training. So, we teach, if someone has a poor connection to their pelvic floor, teaching them where it is, how to engage it. It's not all about Kegels, but some people, I'm in the camp, there's some camps of pelvic floor PTs who are like, never do a Kegel. And I can like get on board with that sometimes. That's fine. There's others that are like, that's all they do, which is very rare. That used to be the case. Now I think a lot of us are in the middle of like, there's certain people that could benefit from learning how to engage their pelvic floor. And the word Kegel or Kegel just came from a doctor in the 1950s. He's a German doctor named Dr. Kegel, and he named it after himself. So I tend to just call it a pelvic floor muscle contraction, just because I feel like that's what it is. And I don't necessarily want to keep referring it to a male German doctor. But most people are familiar with that term. So whatever, it's fine. I'll call it a Kegel. But so being able to connect and contract those muscles and what it feels like to relax them. So training that. So many people are like, I don't know if I'm doing it right. Tell me if I am. And that's what we can help people to reconnect to that. And then again, I talked about breath work and the parasympathetic nervous system facilitation. So getting you into more of that rest and digest, bladder retraining strategies. So one thing that we haven't chatted about yet, which is huge, is for people that do just in case peeing. So we've titled this as an acronym, JICking in the pelvic PT world, JIC, JICking, just in case peeing. So as humans, I do think it tends to fall more on women, but some guys do this too. We go just in case. We start as children. We teach our children, like, go just in case. We're going to leave the house. Let's go adjust. You don't know when the next toilet's going to be. Go to the bathroom. And as a kid, that's fine, right? They don't have the brain development to wait and know. But as you start to get older and you have control of your body, it's not appropriate to go just in case. The bladder will tell you when it needs to go, because if you start emptying it more often than it's actually getting the ability to fill, it will over time. The bladder is a highly trainable organ. It is really connected to our patterns and our habits. So if we start going every hour just because like we're working at home and there's a toilet there and we're like, oh, I don't really have to go, but I'm going to get on a meeting here in a minute, so I'm going to go, and we do that every hour, it will start to train the bladder to feel like it has to go more often. And if you do it once in a while, right? Say you get up, you had your coffee, a few waters, you're going on a 4-hour road trip, pee, that's fine. I don't care, right? Like, it's fine. There's certain situations, but in general, if you're just going to go out running errands and you're going to pee before you leave the house, like, maybe think about it. Like, can you find a bathroom somewhere and go? And then that gets into whole other issues of people not wanting to go in public restrooms and all that, but that's what, I'm not a psychologist, so but I can just encourage in terms of what I know for the physiology system, that that's not a great thing to do. The other issue is if someone's worried about leakage, they're like, well, what if I can't find a bathroom in time and I don't think I can hold my bladder? Then it's like, okay, then find a pelvic floor PT, because that shouldn't be the reason that you're doing that just in case peeing. So a lot of retraining and education of what is actually right, because so many of us don't even know that's not okay. I teach patients that all the time. They're like, God, I've been doing that since I was probably 20. So learning that. We do a lot of stretching because a lot of times there's tension patterns. So teaching people how to release certain areas that are being held tight for certain reasons. I can use biofeedback, which is a form of feedback. And I use lots of feedback. I use verbal feedback. I use tactile feedback, meaning like words, touch. But one way that can help people to connect to their pelvic floor, it's a tool in my toolbox. I don't use it all the time, but I use it once in a while, is biofeedback. And that is a visual. And so there's this, I should have brought it in actually, but it looks like an old school little Game Boy. And there's different kinds. Some clinics will have actual desktop computers with it on. I think that's less common these days, but they have these little tiny kind of, it's about this big. And it has a little cord connected and 2 little electrodes and these little sticky pads that we place, so small, but kind of right along the side of the anus. And that's going to give us a snapshot of what's going on in the pelvic floor. So we can work on having people learn how to relax using it. So if someone has a high tone or a tight pelvic floor, which I find in a ton of patients, which can lead to a lot of different issues, but learning how to relax those muscles using the biofeedback, because then you're seeing it's putting it on a screen and it's showing if it's high, it means those muscles are really tight. And then learning to relax them, you'll see it actually relax. We actually use it a lot with pregnant patients to learn how to relax their pelvic floor when they're in labor and delivery, which can be great, help decrease risk of tearing and all that. Because a lot of times with pushing and even with bowel movements, people think they're pushing and bearing down correctly, but they're actually tightening. So that's going to be counterproductive. So biofeedback can be a helpful tool. A ton of bowel health education, helping people to have healthier bowels, not just because constipation is not fun, but because chronic constipation can lead to other issues like prolapse down the road. Talk a lot about all about squatty potties, which squatty potty I think is one of the best inventions that's ever been created. It started initially, I think, online. I never saw it on the show, but I think it was like Shark Tank or something. But squatty potties can be so helpful in terms of putting the pelvis and the body in the appropriate position to have a bowel movement. Toilets are really comfortable and they're clean and they're great in our world, our Western world, but they aren't the best way to have a bowel movement. So squatty potty is the brand name, but now there's so many different just toilet stools out there that are like bamboo and white and black and whatever color you want to match your bathroom. So it doesn't have to look like a white plastic poop stool. Some people are like, I'm not getting that for my bathroom. You can make it look kind of nice, and like mine's like white and bamboo. So highly encouraging that, because that's going to help the pelvic floor to relax correctly so that you're not having to strain. And then vaginal dilators, we use those for a lot of patients that are having pelvic floor muscle tightness that's leading to either inability to use a tampon, a speculum, intercourse, anything like that. And those are, I should have brought those in too, but they're different sized objects. They're kind of cylindrical. There's different brands out there, but they come in like really tiny diameters, like the size of my pinky, and then they gradually get bigger and bigger and bigger. And you're essentially using them at home to help dilate the opening to in between PT appointments to make sure those muscles are staying relaxed. And we can use those for so many different types that can be helpful if you've had a tear kind of in a 3rd or 4th degree tear postpartum, or as you've gotten older, or anyone that's had radiation or surgery or gynecological surgeries or anything like that, where those tissues down there have just gotten really tight and restricted, to help them get back to being able to have a speculum insertion for health reasons, or be able to enjoy like intimacy with their partner. All right, almost done here. I think I probably already went over these, but this will just be kind of an overview. I wanted to put together kind of like a tips and tricks for a healthy pelvic floor. The first and most important is keeping your body moving to the best of your ability. And I think where that is really in between, Elizabeth and I, Elizabeth, your goal is just keep people moving and feeling good. And if you can't, because of these issues, that stops people from moving. And so the pelvic floor, static, stationary sitting is the worst thing for the pelvic floor. Even just walking, right? Going for a walk, your pelvic floor loves that. But if you're leaking when you're walking, that's going to stop you, right? So that's why pelvic PT can help to fix that. So you can keep moving. It's like makes a circle. Avoiding constipation, and really working on that either on your own to figure it out or seeing a specialist. So working on different nutrition changes, fluids, movement, etc. No more just in case peeing. So really trying to stay away from the jicking. Also, the other one I didn't chat about yet is hovering above the toilet. So many people, I know, right?
Well, so now you're telling me I have to not pee before my errands, and I'm going to have to pee when I'm out in public. I always squat over the potty.
Well, that's why they have the toilet seat covers, and your skin is your best immune system. So sitting, you're not, yeah.
So why is that? So explain that. Sorry. So
Yep.
is that because we are holding too much tension when we're holding that squat position?
Yep.
We need to relax.
Yes. So if you're in a hover squat, it's different, right? If you're in a full deep squat, think Malasana squat in yoga, you're in a deep squat, that your pelvic floor is truly relaxing. So that's fine. If you want to just stand up on that or your feet, right? But if you're hovering and doing like a squat hold, that is completely activating your posterior and your entire lower body chain. So your pelvic floor is not relaxing. So your pelvic, it's just when you're peeing, your bladder should be what's contracting, your brain's making it squeeze and contract, and your pelvic floor should be opening and relaxing. So when you're hovering, you're just not, the muscles are kind of in this tightened state. So over time can just not be healthy. Yep. Learn something every day, right?
Mm-hmm.
I know. And then no power peeing. And that kind of goes alongside a lot. I think, we're all in a rush these days. And so sometimes we'll go and like push it out, but really trying not to, just taking some deep breaths and just letting it go. And it's normal at the end to have the stream be a little slower. It's not normal, however, for the stream to be slow the whole time. So that would be something that you'd kind of check in to see with a pelvic PT. And then looking into getting a squatty potty or any sort of like the toilet stools for optimal bowel health. The other thing I see a lot and work on a lot, which a lot of reasons for this, is avoid clenching the glutes or butt muscles throughout the day. And that is a strategy, and I'm sure you work on this a lot, is getting those glutes to lengthen so that they can strengthen. So a lot of times people are butt clenchers because we're trying to get some sort of stability for a weak core. So if the core muscles aren't doing their job, we'll just kind of grip under and squeeze our glutes all day to get that strength. But then the glutes just get really tight, and a tight muscle is not a strong muscle, right? We need, just like our bicep, if we need to lengthen and then contract and then lengthen again. And same thing goes for the glutes. But I find a lot of my patients just have a lot of glute tightness, which leads to pelvic floor tightness. So it's all a chain.
And a lot of us were told when we were little and growing up as young girls not to stick your butt out. So we're tucking our butt in.
Yep. Yeah. Or to suck in your stomach, right? And that's the other gripping pattern I find that creates dysfunction, is sucking in your stomach all the time, right? Pull it in, suck it in, be skinny, be thin, be beautiful, right? So we've always held that tension. And then that's going to think back to the breathing system. If you're tightening your core all the time, you can't breathe down. You're only going to breathe up, and that's going to lead to all these other issues. So yeah, and all these other clenching patterns. Practice diaphragmatic breathing frequently. It's healthy for the mind. It's healthy for the body. It's just a healthy way to breathe. And then topical estrogen use. And I put that again because I just think that there's so much lack of information about how much that can truly help people.
Mm-hmm.
So,
and I would imagine that's something that people would want to go and get their levels checked, find out if
go to your
you're,
doctor,
deficient and or lower than optimal, right?
Of
and
course.
then go from there. But
of course. Yeah, absolutely. Like chat with your doctor about it. But I think that is all. And then that's just my clinic. So we're located in like Oswego too. That's how Elizabeth and I connected. But our website has a lot of good info on it. And our social is Mendwell Health. But let me get out of here. So that is what I had to share.
There was one question that came up, Eryn. I know we're like right at time, but if we just want to dive in just with a little bit more we talked about the diaphragmatic breathing and the pelvic floor and the diaphragm kind of working together. When we were on Instagram the other day, it came up around like when you're working out, right? And like I have seen this, some of my clients have had comments about like sometimes when they're like in an exercise and they're on like the effortful part of the exercise, sometimes they'll feel a little leakage there, or like they're not sure, that's one thing, or they're not sure like where they're supposed to inhale and where they're supposed to exhale, right? So can you comment on that really quickly, just on like what's correct and the most beneficial for our
totally. Because that's what when I think the difference between pelvic PT and other PT, and not always other PT, I'm sure there's other orthopedic PTs that work on breathing too. But that's the difference is I hound on, because I do a lot of hands-on manual and I also do a lot of exercise. My patients like sometimes make fun of like how much, and if you were listening outside the door, it's like you're hearing all these weird breath moves, like, because it's so important. So essentially, anytime you're doing the effortful part or the hard part, essentially, of the exercise, and that can be the both movements of it. So but essentially during that, when it feels challenging, that's when you want to do your exhale. So blowing out, because that's naturally when everything's gonna do this. The biggest part is you just don't want to breath hold. That is the piece that when you're doing, and then that gets harder, that if you're doing really heavy lifting, like CrossFit and things like that, that's what's tricky. I work with like CrossFitters where it's like they have to do a Valsalva, which is just a fancy word for like actually pushing out and tensing their core and holding their breath, because that truly does get the most kind of muscle activation, but oftentimes they'll have leakage with that. So really trying to find strategies, but it's the exhale with the hard part. So even though if for a squat, usually the hard part is going up, but you could exhale going down technically. And then I usually say if there's any pause or stationary part of the exercise, that's when you take your little sip of air. And then when you do the hard part again, that's when you exhale. It's just the general concepts that
makes sense. Yeah, that makes sense. And, and I guess I would just make a comment, from the perspective of, you mentioned CrossFit and how there's some challenging breathing patterns with certain types of exercise. And, what I see, and I really encourage my clients or anyone who's listening to think about is like, first of all, getting your exercise, getting your movement. I mean, that's the highest priority. You want to enjoy being in your body, feel healthy, feel fit. But there's just so many modalities of exercise, and looking at kind of the holistic piece of going like, okay, am I like pushing myself so far in this direction? Whether it's like, I see a lot of like that chronic cardio or whatever, pushing myself so far in this one direction, but then like that's having a negative impact in this other area. I might be running into all these other things. And it's kind of like, as we go through life, we're just kind of constantly trying to navigate like, okay, what can I do to really like stay optimal in all the areas as much as I can, feeling great, getting my exercise, but not like compromising these other things. That holistic view.
Yeah, definitely. I think that some people just do a certain exercise because they've heard about it and they just want to do it. And it's like, well, do you like it? Does it feel good? Right. And like finding that, like it took me years to figure out, I don't like going to a gym. I like what I do, yoga and Orange Theory. That works for me. But like, I like Orange Theory because I was an athlete and I like that like group fitness, but other people, they don't want someone talking to them. So they like going, and it's like finding those, like working with a personal trainer that really has one-on-one attention, all that, because movement's the important part, but you don't have to push yourself so hard. Like
Yeah.
you don't have to do cardio all the time, right? I think there's so
Yeah.
much more knowledge about women's body and how we don't need that as much as we think we do.
Right.
Like it's good for the heart in
Right.
certain ways, but we need the
Yeah.
strength and the muscle and it's okay to have muscle.
Yeah. Well, and
Yeah.
I think too, like just giving yourself that permission to really tune in, like anytime you're moving your body and exercising is like a great opportunity to tune in to your body and to yourself and what you need. And it changes over time, like we grow and evolve. And I think when we do give ourselves that moment to tune in, then you can notice like some of these things that you're talking about. I think some of the time we just shove things
So,
to the
yeah.
side. We're like, I
Just get it
ignore that.
done.
I'm not paying attention. I'm busy. I'm just going to like get through my day and my workout or whatever. But
Yeah.
it's like, no, like give yourself that permission to tune in. Am I enjoying this? Do I feel good moving in my body? Are there these symptoms and things that are getting in my way that are making me not want to participate in whether it's a workout or just life activities,
Yeah.
like just knowing that there's resources like you out there to
Yeah.
help. So
Yeah.
yeah, so
Absolutely.
this has been super great. Thank you so much for
You're
giving your
welcome.
time. And again, I don't know if you want to pop that slide up one more time with your
Yeah.
contact info,
Yeah. Let's do it.
just in case anyone didn't catch that. But Eryn's phenomenal. She's on Instagram. I am also on Instagram. My handle is at Present Mind Fitness. And my website is also presentmindfitness.com. So if you're looking to connect with either of us later, we would love that so much. But Eryn, thank you so much. This has been so great.
Thank you. I know it's wonderful.
All
Happy to
right.
be
Thanks,
there and learn.
everybody.
All right.
All right.
Bye.
Bye.